Greetings, everybody. I'm currently in Chicago. I work both in Chicago and in Tirupati every other month. My goal today is to give you an idea on how I approach non-arthritic hip pain through a case presentation. So here's a 19-year-old female with chronic left hip pain, some low back pain, no trauma, no other medical problems, no leg symptoms, no radicular symptoms to the leg, insidious in onset, and no other joint complaints. So this history tells me that it's not polyarthralgia. There is a component of back pain that may be causing hip pain, or hip pain can cause back pain. So that's my thought process. I did not find any other relevant history that's concerning for non-mechanical hip problems like night pain or rest pain, and no acute trauma, so I'm not worried about a fracture. Then I went on to examination. Spine exam was normal except for mild ipsilateral left SI tenderness in the same area superficially. That does not mean that the SI joint can be palpated very well, but in that area, general area, there's some tenderness. The tenderness superficially will be skin, fat, muscles, and ligaments. So muscles and ligaments in the left side are tender. No generalized ligamentous laxity. General idea that if the hip is unstable, like it's loose, right? We'll get an idea. A specific hip exam showed that the right hip, which is a non-painful hip, has flexion, internal rotation. Internal rotation at 90 degrees of flexion to be about 25 degrees. Healthy is 20 to 30, so well within the range. More importantly, it's painless. On the left hip, her internal rotation is grossly restricted. She has an external rotation deformity of 10 to 15 degrees. So it's minus 10 to 15 degrees. And more importantly, there's pain in the groin with further internal rotation. And then external rotation was 60 degrees, well within normal limits. So a healthy range of motion is FER of 60 and FIR of 30. A lot of people may not have it, but if they don't have that motion and have pain, then you think about mechanical causes. And external rotation was not painful at all, painless. Faber, flexion, abduction, external rotation test caused some groin pain. So what all this tells me is FIR being decreased, right, is from a bony mechanical problem in the groin area. FIR being painful is very sensitive but not specific for hip any pathology. It's very sensitive for hip pathology but does not tell you which problem it is. But restricted motion tells you that it's probably impingement, and not having pain in other directions tells you that it's not a generalized inflammation, not arthritis. So that FIR becomes the impingement sign, the flexion, adduction, and rotation pain becomes very specific when there's limited FIR with pain in the groin and without pain in other directions, right? The next step is get a plain X-ray. Look at this pelvis AP view, which is the most important X-ray view when you work up mechanical hip pain. Mechanical hip pain X-ray shows you the bony morphology the best, not a hip X-ray, but AP pelvis, so that you know how the hip is positioned on the pelvis and how the acetabulum is oriented to the rest of the pelvis. If you get an AP hip X-ray, you would not know how the pelvis is rotated or tilted, so what your readings on the acetabular coverage will not be as accurate. So this is a good X-ray, no rotation, right? Mid-sacral line going down to the pubic symphysis, Tilt is quite adequate. The foramina are adequately seen. They're not too big like an outlet view and not too small like an inlet view. I can't tell the distance here from the coccyx to the symphysis. Maybe a little more than ideal, but well within acceptable limits. It's a good X-ray. Then we're going to focus on the left hip. So on the left hip, there are no pathological lesions, right, grossly. Head seems reasonably round. The problem is the facial line is not perpendicular to the neck. It's extending onto the neck superiorly. That's called epiphyseal extension sign, which is a sign of cam morphology. So you can tell that this head probably is not perfectly round like it looks here. Somewhere here there'll be a bump at the head neck junction, right? Epiphyseal extension sign. The fovea is well located, not in the weight bearing area. That's good. Round, otherwise round, good head. Reasonable sourcil and joint space. Slight widening of the lateral joint space compared to the medial side sourcil space. What this tells you is there probably was cam at a young age that remodeled this area and made this space wider. So as she flexes up, some of the sphericity is accommodated by this acetabular remodeling. And on the acetabular side, the teardrop, this ilioischial line, and the teardrop is reversed, saying that the acetabulum is a little deeper. It's not a very accurate sign. It's just a gross thing to say that maybe the acetabulum is deep. That's the posterior wall of the acetabulum. And that's the anterior wall. So there's no crossover sign. But if you look at the actual percentage coverage of the head at the neck axis level, this line is along the neck axis at this level. The center of the head is somewhere here. So the posterior wall is covering more than the center of the head. So excess coverage is the posterior side. Then the excess coverage on the anterior side. Normal is about 20%. This is almost about 35%, 40%. The posterior normal 50. This is almost 60%. So there's global overcoverage of the femoral head by the acetabulum, a risk factor. Lateral view, femoral head has nice contour in the back, but does not have much of a contour in the front, almost like a straight line with no neck concavity. There's actually a bump anteriorly in the neck. So ideal morphology will be more like this. So all the bone that's beyond this line is excess bone, a risk factor for cam impingement. We routinely get an MRI scan these days to make sure that there is no other pathology and missing something else like AVN, bone marrow edema syndrome, synovitis, things like that. It's not as diagnostic, but in this particular case, you have a very nice impingement cyst in the head neck junction. So with this information, we know that the hip is impinging. Her back pain is not causing the hip pain. It's probably the other way around, where the hip pain is probably causing stress in the back in a young person. And there's clear signs of impingement on clinical exam, clear radiographic abnormalities that can be treated, that the causes of impingement that can be treated readily. An MRI confirms that there's no other pathology and it's impingement with impingement cyst. So the diagnosis is made. Pain is from the hip joint. That's the first thing we need to know. The first step on diagnosis is the pain coming from the hip joint. Second, is it mechanical? Yes, right? No other disease process. Impingement sign was positive with decreased FIR. So that's a clear sign of anterior impingement. No arthritis. No other primary tissue problems like cartilage problems, no dysplasia, and no muscle dysfunction. So that leaves us with only one possibility, that's a femoroacetabular impingement. And for treatment, the patient is quite active and wants a curative treatment. That means that she doesn't want to take medicines forever for her pain or not be active. Activity modifications and medical management can help, but that's not enough for her. The treatment plan was, we know that non-op treatment does not relieve impingement. The goal is to get to 20 degrees of FAR with the round head. The anterior rim can be trimmed to 20% by about 5 millimeters. Labrum has to be repaired because it's going to get loose when I remove the rim. Cam osteoplasty is very important, so it does not continue to impinge. And capsulorrhaphy is optional. So that's a pre-op plan. Here's intra-op exam under anesthesia. Max rotation minus 10 to 15 degrees.
Yeah.
She does not even go to zero. Here's arthroscopy. Starting portal, adequate distraction, putting the needle through lateral aspect where it's the safest to enter. It's typically 2 portals. This is the anterolateral portal we made with the needle. Then while visualizing through this portal, we made the second portal. Now I'm going to show a video of the case now. So the 2 portals established, we're doing a capsulotomy between the 2 portals with a sharp knife. You can see the labrum is rounded and soft. Normally it should be triangular and firm. So capsulotomy for my technique is very important. Once you do the capsulotomy, it's very easy to go in and out. The only risk is there's some element of instability after capsulotomy. So you want to repair and protect the hip for a few weeks. So cutting the capsulotomy all the way down, it's the left hip, as you can see. So we're going down to, say, a 9 o'clock position. You can see the iliacus muscle and the psoas tendon coming into the view. That's a distal extent, is psoas tendon, the psoas gutter. Right? So superiorly, we go to 12 o'clock position for anterior impingement. So 9 to 12 on the left hip. So once you complete your capsulotomy, it's a wide open, like an open case, except you're doing them through small, tiny incisions. Orientation will be much easier, and passing instruments is also easier with the capsulotomy. So that's the last little bit of connection between the 2 portals. And now we are done. Then we start diagnostics. Look at the labrum. That's pincer damage of the labrum. The labrum got pinched between the femoral neck and the rim. Cam and pincer diagnosis should be an intraoperative diagnosis looking at the damage pattern and not a preoperative diagnosis based on coverage or cam morphology. Palpating the cartilage for health. See how the labrum is all crushed and rounded and red. That's a normal cleft, embryological cleft in the acetabulum being palpated. Once we looked at the damage pattern, now we're taking the rim out with a burr. It's a 5.5 millimeter burr that's removing the anterior rim of the acetabulum. As I remove the bone, the cartilage underneath is getting exposed. For this part, we don't need fluoroscopy because the burr gives you a guide on how much you removed. It's a 5.5 burr. So if I removed a burr width of bone, that's 5 millimeters. So this is the labral tissue and this is the articular cartilage that's getting exposed. So in this particular case, I did not excise that articular cartilage. I chose to wrap that cartilage and the labral tissue as one soft tissue mass and put it against the newly formed rim. We recessed the rim back by about 5 millimeters, so we're putting all the tissue back to that rim. There's a suture anchor. That PEEK material goes into the bone through a drill hole. It's knotless. The sutures are already passed around the labrum. Then I tighten the sutures and cinch the sutures into the anchor. It's called cinch lock. It's a trade name. You can use any anchors you want. So we use 2 anchors in this particular case and finish the labral repair. Look at the red area. So this is the cam extension. See how the head is extending, the cartilage is extending onto the neck. And this is the red area where it's pinched, pincer. So this extra cartilage is causing damage. We use fluoroscopy liberally at this phase because the roundness of the head should be confirmed by fluoro also, not just by visualization. Same burr, removing the abnormal extension of the epiphysis, going medial to the red band on the head-neck junction. So cam osteoplasty typically goes from about 6 o'clock to 12 o'clock, the entire anterior aspect of the head-neck junction. Sometimes you go even beyond 12 o'clock superiorly, but almost never beyond 6 inferior. Going more and more lateral to make sure that the roundness is restored to the head-neck junction. And then capsule is closed with the 2 sutures. So rehabilitation, patients are allowed weight bearing as tolerated from right away. They can walk to the bathroom the same day. Crutches are recommended for 1 week, though they're putting full weight. It's more for balance. Post-operative day 1, they start exercising on a bicycle, stationary bicycle. Do half squats to activate the muscles. Range of motion exercises by a family member or a physical therapist. Gradually increase strengthening and speed for the next several weeks. I usually lift all restrictions off by 6 weeks. Crutches off at 1 week, and then they can start running and playing at around 6 weeks. So this is a case of FAI, femoroacetabular impingement, mixed type. FAI is pain and damage from normal movements of abnormal bones. It encompasses all types of FAI. The bones are slightly abnormal, slightly or a lot abnormal, and they cause pain from normal movements of that hip. FAI is quite common in India. I see it all the time. It's not diagnosed readily. The reasons being, 1, the symptoms are mild and vague, so most people don't seek attention. They modify their activities and they do okay. It's almost always a clinical diagnosis. So unless you suspect FAI, you're not going to make the diagnosis. So people who are not aware of it or have a low suspicion will not pick it up that readily. And more importantly, there are no consequences to missing the diagnosis. It's not like a stripped epiphysis that's going to become worse, or it's not going to be a tumor that you missed that precluded limb salvage afterwards. So no one is going to come after you for missing the diagnosis. Even in America, it takes a long time for people to be diagnosed. There is risk of arthritis in general. That's the reason I operate on these patients early when I diagnose them. But the arthritis seems to be less in India. I say that because I see 60 and 70-year-old patients coming with big cam bumps and not much arthritis and more recent onset of pain. So I'm not going to scare 60-year-olds saying that you're going to get arthritis and try to operate on them. So I think the risk is a little less in India because of less activity maybe, and maybe some biological protection. So a lot of information that I teach, I put it on a website called hippreservation.com. All the notes there are updated in the last year or two. So in conclusion, labral tear is not a diagnosis, it's a finding. It's your duty to identify the cause of labral tear, the mechanical cause almost always, and treat that, which is more important than treating the labral tear itself. MRI is a good screening tool, not diagnostic often, but rules out other pathology. If the MRI is normal, then you focus on mechanical cause of hip pain and try to make the diagnosis more confidently. Hip pain almost always has a diagnosis. It's your duty to make the correct diagnosis so that you can treat them appropriately. Both FAI and dysplasia are pre-arthritic. So if a young person comes to you with hip pain, it's a good idea to make the diagnosis and offer treatment to prevent premature arthritis. Both have good treatment options, mostly surgical, but the surgeries are well tested and have good track record. I conclude with this announcement that Amara Hip Preservation course, the third biennial course, will be on December 8th and 10th in Tirupati. Anybody interested can contact me or go to Amara Hospital website for the registration details. Thank you for listening.